allow me to introduce you to our moderator, Ron Elwell, who is the president and co-founder of Swoop and IPM.ai. That's a real chemistry company. And he'll be leading this session on inclusive AI and the path to equitable precision medicine. Thanks so much, Ron, for joining us and for leading this panel. I am going to turn it over to you now to introduce your esteemed panelists and get us started.
Great. Thanks so much for that introduction, Mary. And we are excited to be here and talk about something near and dear to all of our hearts, but not just health equity, but how AI can play into that. And joining me today on the panel, we're lucky to have Dr. Irene Dankwa-Mullan, who's the Chief Health Equity Officer and Deputy Chief Health Officer of IBM Cloud and Cognitive. We have Michael Crawford, who's the Associate Dean for Strategy, Outreach, and Innovation at the Howard University College of Medicine and the founding Executive Director of Howard University's 1867 Health Innovations Project. And keeping us all honest on the technical side, we have Evon Okidi, who is a data scientist with Medidata Solutions. So thanks so much for these folks for dedicating their time to us today. Excited to hear what they have to say about this topic. Just to kick things off, I think today, a reoccurring theme of this conference has really been around how do we collectively invest in health equity, the kind of future-proof health equity, to ensure that it's more than just about meeting a moment, in the current time and space, but really, as I said, just how do we future-proof it for the future? So I'd be interested in the panel's thoughts around that question, and how they think that this relates, especially to the promise of inclusive AI. So Michael, maybe you could kick us off with that.
Sure. Thank you, Ron, for that introduction, and thank you, Real Chemistry, for the opportunity to contribute to this meaningful and timely dialogue. Your question is pertinent because I think it's a question that we all contemplate within the industry of how can health equity be a sustainable health and business imperative for the healthcare ecosystem. And I think what COVID has showed us is going to take a collective effort of traditional and non-traditional partnerships coming together to look at ways in which we can advance and acknowledge gaps and best practices to accelerate the concept of health equity throughout our healthcare ecosystem. I think it also starts with an investment in workforce. I know a number of your panelists talked today about D&I, and sometimes D&I and health equity are used interchangeably. They are different, but there is a relationship there in terms of what it looks like. But I think that there needs to be an intentional strategy to diversify our healthcare workforce. I think that we also need to look at infrastructure, particularly around data collection and innovation, as well as how we deliver technological solutions. What we saw in the pandemic is that our public health infrastructure is porous, it needs investment, and has gaps. So I think that is an area that needs to be bolstered. And I also think governance, which is not often talked about when we think about health equity as well as AI, that we need to diversify our governance structures at the board level, at the federal and local level, as well as in our investment community to ensure that we have a diverse representation from a governance perspective to ensure that the solutions in health equity are being thought of in a way that is shared, there's a shared understanding, and also that there is an opportunity for folks to weigh in on how it should evolve and iterate over time.
That's great. Thanks. I mean, there was a lot in that answer that I think we're going to come back to and hopefully have a chance to expand upon in a few minutes. But Irene, I'm interested in if you have any thoughts or pick up on some of the topics that Michael raised.
Yes, absolutely. But I also want to say I'm delighted to be here, and I'm thankful for the opportunity to participate on this panel. That's a great question that you're starting out with. I think we can all collectively invest in health equity, ensure that it's not just about meeting the moment by boldly communicating our commitment. What's our commitment to society? What's our commitment to our members? Our social mission or our goal towards a shared responsibility, right? So what are our values? And I think that we have to think about what kind of values do we want to portray, and do we have one? And what's our organizational commitment to sustaining a healthy workforce or a healthy population? What's our long-term commitment? And who are we serving? Who do we really serve? So I think, investment, first of all, is a key word, but it's important to really emphasize our role, our organizational role, and what's our role in society in affording a fair chance at health equity to everyone, because health is a shared value. And what makes health particularly important is because it's essential to our well-being. It's essential to our ability to participate fully and contribute fully to society. And so, when we have ill health, when we have, chronic disease, it threatens our ability, to participate or contribute fully and even to within our organization. So making it an intentional collective effort, communicating our value. The bottom line is, we know that not every single organization or institution can meet all of our health equity goals. But if we think about where our health footprint is, right? And in terms of organization, it's in 4 key areas: with our employees, with our members or our clients that we work with, or the constituents that we serve, with our communities that we're embedded in, as well as the environment. And so part of what we need to do is to think about, really shift our business model to be accountable, not just to shareholders, but to the stakeholders, the health and well-being of our employees, our suppliers, the communities in which we are. So basically, I think that's a great start. I think ensuring that, we are communicating our values, our social mission, and because we all, as employees, we want to make sure that we are, living a healthy life. We want to make sure our employees are providing, getting the minimum, a wage that they can confidently put food on the table to feed their families, that our clients also want to know that they're getting the products and services that they want and deserve, either with technologies or with our products. And we want to live in a society that is fair, right? And on a planet that we can all breathe. So I think having that sort of commitment and value to society and our social mission will help us collectively really, a long-term commitment will help us move and not just think about meeting the moment.
That's great. I love your employee members community environment, right? It's a great way to think about it, right, holistically. We are gonna, and I think that's so true. I am going to drag us back to technology and AI at some point, though, since that's kind of our focus on this one. But Evon, I wonder, as you look at it, and you kind of, our background's a little bit more similar from a data science standpoint. How you think about this.
Yeah, thank you, Ron, for having me here. This is a great thing that you're doing, and I'm glad to be part of this panel. So I would say I do agree with what's been said by Irene and Michael, but also I think when organizations like ours are in this healthcare space, one thing that we can do to really make sure that we're trying to build an equitable healthcare system is to continually build technology. And in the process of doing that, because I think technology is what's going to get us to try and cover some of the gaps that already exist right now. And to do that, make sure we're making it inclusive and building trust along the way. So, like one thing that was really exposed during the pandemic was how there were areas in the country where people did not even have access to like pharmacies. Like you couldn't go somewhere to get a test. You couldn't meet your doctor. And in one proposed solution was, okay, well, let's do telehealth. That's technology there. But where it was built, there were still issues with it. Not everyone has access to it. Not everyone knows how to use it. Not everyone actually has a device or lives somewhere where you have the privacy to talk to your doctor or to, have access to actual healthcare. So I do think we need to keep building technology because, as we saw, that was one of the things that was sort of helpful in trying to fill the gap where like people cannot actually travel somewhere else or they need to be at work. But as we're building that technology, also have a way to meet back with community leaders and meet back with the actual patient, like end users, and try and explain, this is what's happening, this is how we're collecting your data, this is because we need the data to sort of build all this, but we need you to trust us enough to give us your data. And we also need to come back to you and say, this is what we did with it, this is how it's working so far. And I think to me, technology is the way we sort of future-proof healthcare and make it more equitable.
Yeah, that's great. And this issue of equitable access to technology is just critical, right? It's a little bit of an offshoot of the AI that we're talking about, but a huge issue to make this work. If we bring it back around to kind of inclusive AI and machine learning, we all understand, we all have experience with this, and we understand it's just a tool, right? And it's not, a panacea. And like any other tool, if we use it right, it can be incredibly helpful. If we use it wrong, it can actually, set us back or create mistrust, right, with some of the stakeholders in it. So a question I have for the group is, how do we erect guardrails, or is it even possible to erect guardrails to ensure that the technology kind of helps us further our health equity goals and commitment, rather than, and rather than creating unintended consequences, right? How do we protect against that? And, I wonder if, in your organizations or some of the work you've done, if you've given this some thought, if you have some things in place, I'd love to kind of throw it open. Irene, I don't know if you want to take the first shot at this, but I'd love to hear what people think about that issue.
Yes, absolutely. I can start because I sort of have, I would say, 5 approaches that I think about in terms of equitable AI, inclusive AI, ethical AI, and really moving the needle on precision medicine. And what we could do, right, in terms of enhancing equity. And the first approach is really advancing our science. Because I think we really need to be more robust. We need that comprehensive data strategy to really inform our current precision efforts. And so when I talk about augmenting our science evidence base, we know that our data sources for our predictive algorithms, our risk stratification algorithms, often rely on these different data sources, rely on research evidence, real-world data sets to supplement clinical trials. But we fundamentally have a translational research evidence bias, right? An evidence-based bias stemming from what we are currently doing with our research translation. With precision medicine, basically, our medical clinical decision making is driven by an evidence base, right? And what makes up that evidence base? Who defines the evidence, right? And what are the standards? And is it really inclusive? And so we know when we, in clinical care for precision medicine, the evidence is based on a synthesis of literature, including the studies, including research trials, or even practice-based guidelines, what's fed into consensus studies. And so if these clinical studies, research trials, consensus studies are not diverse or inclusive, then we run the risk of really having bias or perpetuating disparities in care and outcomes, because our clinical practice and decision making rely on the research translation. If it only captures randomized controlled trials that are published, or clinical trials that are not diverse, or real world evidence that really does not include a diverse population set, then we already have a translational science evidence-based bias. The second one that we really do not, I think about often, that we also need to address is the bias or discrimination that is in the healthcare system, in particular, the expertise of the healthcare provider or the clinician, right? So I say that clinical decision making is based on evidence, but it's also based on the experience or the expertise of the provider that's taking care of you, right? And I think it's an integral part of translating that evidence into practice, right? You may have a patient that will come to a primary care or a hospital with symptoms, and then the primary care practitioner or the doc will determine the course of action based on his or her or their assessment or beliefs, often in combination with the patient lab or imaging data, and pooling in guidelines that has been based on evidence. So their actions or what they provide to that patient is a reflection of their beliefs regarding a patient, what they think the patient has in the course of treatment, after a thorough examination. But those actions can also include unconscious or conscious bias stemming from their experience, right? And so the actions can also be influenced by their compassion or their sense of providing optimal health outcomes for their patients. So I think that one of the things that I talk about is, provider expertise is key, but that's why we also need to ensure a diverse health workforce or an equitable health workforce. And I also, a third one that I think about, I talked about evidence-based expertise of the provider, but there's also exclusion, data exclusion, or a lack of diversity of key information, whether we look at social determinants of health or whether we aggregate our data by race and ethnicity and geography and gender, disability status. And we know that our EHR or the data that we use in our analysis or predictive analytics sometimes come from EHR systems or claims data that typically favor those patients who may have a robust health data profile. And it may be missing those, medically underserved populations who may not be in that healthcare system or data. So those are some of the issues, right? And the final one that I want to talk about is empathy, right? And how much the patient values or preference are integrated into that aspect of care or into our data sets that we're looking at, and whether we take into account, the lived experience about the people or the patients that we're looking at, or all the factors, social factors that make up that data. So data empathy is also what I stress in terms of trying to figure out, really addressing these barriers in AI, inclusive AI, as well as in advancing health equity. Because empathy can potentially translate into our data, translate into our models, and translate into how we take care of our patients and address disparities. And so I'll stop there since I've
It's terrific. I don't know about the rest of the audience, but I have been writing down Dr. Mullan's 4 pillars for health equity and her 5 rules for equitable AI. So I'll footnote you and give you credit when I use them again. But
yes, thank you.
Evon, maybe as our, this is right up your alley as our data scientist expert, but I'd love to hear your thoughts.
Yeah, well, I do think we all agree that it all comes down to the data that we have, which unfortunately we all know can be very biased, and whatever models you build with it will reflect that bias if you're not careful. But also, because we have this data that's very biased, we're able to see who is missing there, what information about them is missing, and essentially where are the black spots, where are we not seeing people, where people's like why are people dying younger than other places, and et cetera. And I think the first thing we want to do is to diversify like the patient profile. So I know right now there's a huge push to have diversity in clinical trials, and which is amazing because like organizations like Medidata have been like pushing that, so that when we're trying to organize clinical trials for biopharma and like research organizations, we sort of embed that into it. So if you go to this place, you're likely to have patients of this race or ethnicity, or you can actually recruit older patients here. You can, it's all about trying to build that diverse patient database for the clinical trials, but also making sure that healthcare itself, like actual care programs, so just not in clinical trials, but making sure that communities that you will eventually do trials with, they actually have everyday care. You can identify areas where physicians are not seeing patients that they should be seeing. It's very disproportionate. You're only seeing people who can take time off work to come see you if they have a problem. You're missing out everyone who has to actually go to work and will never be able to come there. And so I think the first thing is trying to make trials more diverse, trying to make the health records more diverse. But the people who are actually working on the algorithms, so people like me, you want to have a workforce that's diverse. You want to be able to have people like me who will look at something like, recently I watched a panel by this group. They had built this model that could look at X-rays, but somehow X-rays could identify Black patients. And so they gave it to all these doctors. There was nothing, they did not have any information about the person, but just because of that image, they were able to really accurately identify Black patients. And, and she was like, oh no, this is a problem. Let's look into it. And they tried everything. It was like, there's nothing, they could see nothing with their eyes, but this algorithm says, oh yeah, definitely Black patients. And it was very accurate when they looked at self-reported race. And, the one thing that she said was, well, I was very confused about this. I got my research assistants to look into it, look at the algorithm. And everyone else was like, but why is this so important? Like, why is it so important that this can, why are you worried about it? But that's the whole idea. If I feel like, I have built something that can accurately define my race without a physician having seen me, they've just seen my X-ray and they said, oh, this is a Black patient, I would already feel like, oh, wait, will I be getting the care that I deserve? So for me, building that, it will be immediately a red flag. And I feel like that's a thing that you need to have people who, first of all, you've lived the experience, so oh no, this has potential to be used for evil, even though it's being used for good right now. And I do think that's a good thing about people who are building it and people who are using it. And so that means when you have a diverse group of people who will build the algorithm. You have a diverse group of people who are testing the algorithm. And also, as you're working with it, and right now there's a whole aspect of ethical AI that's, everyone's trying to make sure that everything that you're building, passes the best checks, the best quality checks. And you really, one of the things that they do is you look at your data, where was it sourced? Who collected this data? How was it collected? Does it represent the population as it is? And what will this product be used for? So you might build a product that's, it's a good product, you want it to be used for good, but does it have potential to be used for bad? And that is something that it's not something that jumps out of you the moment you see it. It's like when you're writing code, you always have to think of edge cases. Like, oh, what if, you're supposed to enter your name, but you enter a number? What is this supposed to do, So it's, you have to have people who are thinking about it ethically, and you're thinking, oh, as a Black woman, will the results of this product be used against me? You're thinking, as a child, will the results of this product, like, you have to think of all possible solutions. It's not possible, but when you have a diverse group of people, something in your lived experience makes sense that doesn't make sense to someone else who does not have that experience. So I think, to me, is get everyone involved, make it diverse, and then get people who are working on it very diverse, and be very intentional with what you want your AI product to do.
That's it's a great kind of a great personal example of something that you saw, right? And kind of the impact of having that that diverse workforce, being able to see through what someone else didn't realize an issue. That was terrific. Michael, any thoughts to add into this topic?
No, the only thing that I will add, because I think that my colleague spoke very comprehensively about the topic in your question. One thing that we're doing at 1867 Health Innovations Project, as we work with corporate partners as well as entrepreneurs under this inclusive product development process, we always are looking at how we can provide technical assistance with respect to their product development process and even algorithm development, primarily in the pre-design phase, because sometimes if you're not addressing some of these issues in that pre-design phase, some of these things go unchecked. Some of the right questions are not being asked, and some of the right data is not being used to either train the algorithm, map the data, or curate the data to generate robust insights. So we are really working with entrepreneurs in that space. And one example I can point to is really in the dermatology area, in facial recognition, looking at different skin types, and having our providers work with some of these collaborators to annotate certain images, because we all know that pigmentation is different across different race and ethnicity groups. So I think having a level of insight from individuals that work with different skin types on a regular basis, and being able to annotate that in a way that the algorithm picks up on these different variations and pigmentations and skin color, I think is very important. I think there's been a lot of press and attention around facial recognition technologies. Now they're being powered by AI and deep learning and machine learning algorithms. So I think it's very important to get it right from the beginning, prior to it being embedded into a process that is hard to untangle if it goes a little bit too far. And the other piece I will talk about as well is around having an ongoing auditing process. I think after these AI algorithms are commercialized, sometimes in certain instances, they're not being monitored on a regular basis. So I think it's important that you have that infrastructure in place, And if that's through a governance model or technical assistance model, a role that we have been attempting to play with some of our partners, I think that's very important to ensure that we're not perpetuating inequities and bias with these algorithms.
That's terrific. Kind of related to that, Michael, and maybe just, kind of picking up on this piece is, we talked a lot, we have these data issues, that are just kind of intrinsic. We have, the historical bias issues, but it feels like we're at this critical stage in the use of this technology, right? Where we want to be able to demonstrate success. We want to be able to build confidence in these things. So if if we look at how do we move the needle, how do we make a difference, in the next, 5 to 10 years, what are 2 or 3 areas you think that inclusive AI can have the biggest impact, right? Where can we, in 5 years in this world is a relatively short amount of time. Where should we focus? Where should we go to make that impact? And because we're down to 8 minutes, I'm gonna ask you, we're gonna run through. Everybody, give me a couple examples to keep it a little quick, and because I want to make sure we get to another topic or two as well. So, Michael, you want to lead us off?
Yeah, I'll try to be as precise as possible. I think a low-hanging fruit example is in the chatbot and intelligent agent space. We recently, in the healthcare environment, have seen our workforce decline because of COVID positive tests and different, and then childcare complications. So we've had to rely on a shortage of staff to be able to provide care to the same population, actually an increased population. So I think being able to use AI in these chatbots, intelligent agents, gives healthcare providers an ability to triage care and direct that care to the appropriate care settings. One of the things that we have to be mindful of is that it has to be operating from a robust data set that is representative of the broader population to make sure that you are triaging or transitioning care to the appropriate setting based on environmental and social factors. So I think that that's a low-hanging fruit opportunity. I also think about the genomics space and genomic sequencing and RNA sequencing. I think that it's a great opportunity for us to really realize this precision medicine for all concept. And I think if we start to have this equity agenda around precision medicine and genome sequencing, I think we can bring the right individuals to the table to make sure that we're answering the right question, we have the right insights, we have the right assumptions to address some of these chronic diseases that are disproportionately impacting medically underserved communities. Cancer, women's health, infant mortality rates are abysmal, behavioral and mental health, in other areas like neurological disorders, i.e. Alzheimer's, et cetera. So I think those are some key opportunities that we can really, with intentionality, address with AI.
Terrific. Yeah, I love your chatbot and intelligence agent. That's like very quick, immediate impact. It's great thought. Irene, what are your areas where you think we can make an impact?
Yeah. So, I want to just provide some context because precision medicine, right, we know was established to really accelerate our understanding of individual variability in terms of our health, right, our response to treatment, our outcomes based on those determinants or those factors that influence health. And some of this could include childhood experience, it could include our life course trajectories, cumulative effects of social, racism, stresses, right? And so it's an approach to that we could to predicting and preventing and screening or detecting disease early. But somehow our precision medicine efforts have been skewed towards the treatment. And I want to see more in prevention side. And so I think we're not yet maximizing the potential of AI and machine learning to really address disparities around prevention and early outcomes, right? And also most of our research practices still reinforms these norms of homogeneity in Black, populations, people of color, when we know that there's variability, right? And that and so we also need to apply really standards of intersectionality. So what I mean is, like, we're still looking at Black versus white versus, other populations, but all these populations have different features, different risk attributes that may contribute to their risk or resilience. And so in our predictive models or statistical approaches, it needs to be really more robust than just looking at Black, white. I think it's not that simple, and we need to develop fairness standards and really select the appropriate reference group for comparison, not just looking at, and especially our patient similarity, looking at features and variables that are important, and really considering the complete etiologic context of a patient's health in precision medicine efforts. So, life course experience, determinants of health, and those unique variables. And that's what, we're pushing in our work at IBM and within our algorithms, going beyond just race, ethnicity, geography, but looking at those features that really make us unique.
Fantastic. Evon, your thoughts?
I'm just gonna piggyback on Irene's words, just because it is true in precision medicine. We do need, if we're gonna be precise about different Black people, you need information on Black people. So I still go back to, if in 5 to 10 years, we do not have to exclude a minority group because they were so small. If you include them in a summary, they'll be identifiable, So if in the next 10 years, we have, if you're looking at a clinical trial data set, you can be like, yeah, we have enough to actually dissect this population, into different specific attributes of them. So we don't just have 2 people out of 1,000. We have enough for us to actually build in a model. And I think that would be something that would be very impactful to me in 5 to 10 years.
That's great. Well, this has been, a fantastic conversation. And once again, I just want to thank our panelists for taking the time to speak with us. And, clearly this is, we all knew this going in, you live it. It's a super complex issue, on the data side, on the AI side, right? We're dealing with some kind of, I think, unique issues around biased data sets and, and a lack of diversity in our, in some of our workforce that deals with this, that we kind of have to attack, because if we can't fix those problems, if in the AI ML world, if we can't fix the biased data problem, we have an intrinsic problem. But it's been a fantastic conversation. I appreciate all of your time, and it looks like Mary just got a chance to join us. Mary, I hope you enjoyed our conversation.
I absolutely did. I've been taking notes, and I think that this has really helped to draw attention and shed some more light on the interconnectedness of all the components that are going to have to come together to really, truly help us achieve and advance health equity. So thank you all so much for participating.